This portion of CardioSource video news coverage of AHA 2010 is brought to you by Novartis Pharmaceuticals Incorporated.
Cardiologists from all around the world are convening at the McCormick Place Convention Center here in Chicago. And the big draw? Breaking clinical trials. Welcome to CardioSource Video News. I'm Dr. Randy Martin. The American Heart Association's Scientific Sessions 2010 are fully underway, and we do have some breakthrough trials to discuss this morning. And to help us understand these trials and how they might impact our practice, I'm joined by a great panel of experts. First is Dr. Peter Block. Peter is Professor of Medicine and the Director of the Structural Heart Program at Emory University Hospital in Atlanta. Dr. Christopher Cannon. Chris is the Associate Professor of Medicine at the Harvard Medical School and Brigham and Women's Hospital, and is also Editor-in-Chief of CardioSource Science and Quality. And at the end, last but not least, isn't that what you told me to say, is Dr. Tony DeMaria, Professor of Medicine at the University of California in San Diego, and Tony is the Editor-in-Chief of the Journal of the American College of Cardiology. Well, there are some interesting trials, so let's start off with discussing a trial that focused on heart failure patients who have CRT devices. It's called the SMART AV trial. Peter, why don't you tell us a little bit about this?
Well, the SMART AV trials really measures whether or not AV delay programming, changing the AV delay, is going to make a difference with outcomes of these people that have CRT. They have bad heart failure, ventricles don't work very well. Is the AV sequential delay important? And it turns out, bottom line, what comes out of the box is just as good as playing with it as after it comes out of the box. So this is a negative trial. The trial does not show any improvement with AV programming changes. And, you probably save a lot of money and a lot of time. A lot of electrophysiologists spend a lot of time playing with this AV delay business. It's expensive. Patient has to come in. It takes a long time. Don't need it.
Tony, we do this all the time in the echo lab. I mean, what are your thoughts about this?
Yeah, no, it's very tedious. And when the sonographers get a request to do AV optimization, there's an audible groan. So I think they're going to be very pleased with the outcome. Although it is surprising because in animal studies, you clearly have been able to show that optimizing the AV delay can enhance stroke volume. So a little bit surprising, but very welcome.
Chris?
Well, one thing I think that we have seen a series of patients optimizing lead placement with the goal of getting better enhancement of LV function, that seems to work in the initial study. So that's one way to optimize this and not just do the same routine procedure.
Tony, I wonder if patients not doing well, so they come and we're going to do it out of the box, they don't come. It might be beneficial to look at AV optimization in those patients and see if that's the reason they're not doing as well.
I think you're right, Randy. You might also look at VV optimization, and as Chris says, there may be a role for epicardial lead placement to get that lead just in the sweet spot where you can't access that with the venous system.
Okay, so we've got an answer on that. Let's switch gears a little bit. There's a really interesting trial out about prescription omega-3 fatty acids and whether they could prevent recurrent AFib. Chris, you want to jump in on this?
Well, there has been a lot of background work on the role of fish oils in preventing inflammation, and a series of patients in small trials at single centers have suggested that you could have lower rates of atrial fibrillation in people given omega-3 fatty acids. And so this was a more proper prospective study with careful assessment of the endpoints to see if this worked or not.
Tony, what do you think?
Well, the results were negative, of course, and, from my perspective, omega-3s have had a very checkered history. They've been alleged to have value in a series of things, but there's a lot of negative data. These are more negative data, so I think in terms of arrhythmias and atrial fibrillation, that it's not worth taking fish oils.
All right. Well, we're going to come back to just a second because we might pick up a little bit more of this, but we have a big trial called Closure 1 that's going to be drawing a lot of attention, and we're going to cover that when we come back.
Special thanks to Novartis Pharmaceuticals Incorporated for supporting continuing coverage of CardioSource Video News at AHA 2010. This is CardioSource Video News coverage of AHA 2010.
Welcome back. As we went to break, we were talking about prescription omega-3 fatty acids and could they prevent recurrent atrial fibrillation. Peter, I didn't hear from you, so I cut you off. So what's your thought?
Omega-3 fatty acids have been around since Leonardo da Vinci and I were interns together in 1832, right? I mean, people have been trying to figure this stuff out forever. And is there any trial that has shown omega-3 fatty acids actually have benefit?
Well, in different indications, here this is atrial fibrillation, another arrhythmia that was thought to be impacting with sudden death and ventricular arrhythmia. Some small studies suggested perhaps fewer ICD shocks, but then in the Omega study, looking prospectively to prevent sudden cardiac death post-MI, there was no effect over a year's time. Now, there are two studies for secondary prevention, the GISI Prevenzione Angelis trials, large, 12 and 18,000 patient trials preventing cardiovascular death, MI, or stroke. Right. That are both of those are positive. Published several years ago, but still it's not in the guidelines because people sort of say, well, it's not quite definitive.
Yeah, data on both sides drives me crazy. At our next meeting, there'll be another study that's positive, and who knows what it means.
So Tony, if your patient comes in who's had AFib once, he says, Doc, I'm taking omega-3s to prevent heart disease. Should I continue taking them over the counter? What are you going to tell him?
I'm going to ask him what his triglycerides are. If his triglycerides are high, I'm going to tell him to go for it. And if they aren't, I'm going to tell him to eat a lot of fish.
There you have it, ladies and gentlemen. Dr. DeMaria, the salmon fisher, is out. Okay, we're going to go back now and take a look at another breaking trial. This really drew a lot of attention, and that's called the Closure 1 trial. Closure 1 looked at whether device closure for PFOs plus medical therapy was more effective than medical therapy alone in preventing recurrent TIAs and strokes. And so Peter and Chris and Tony are going to weigh in on this. Let's start with the non-interventionalist first. Tony, I'm going to go, or Chris, I'm going to go to either of you, and I'll come back to Peter in a second. So what do you think?
Well, Randy, the evidence that PFOs are responsible for strokes has really been circumstantial. They're more prevalent in patients who have cerebral events of unidentified etiology, but just circumstantial evidence. And so it's not totally surprising that closing them really didn't make a difference. Now, whether it's the fact that closing it, that having them open doesn't make any difference in the first place, or maybe the devices are thrombogenic, is uncertain. But at least using this device in this trial, it doesn't appear that it's worth the effort to close the PFO.
What are your thoughts?
Well, as Tony said, this comes up a lot, and I think it's with a high prevalence of PFO and stroke, and so how much those are interrelated, I think, is probably the key, that it may explain a percentage of the strokes in people who happen to have a PFO, and that makes it really tough to pick out which patients may or may not benefit.
I'm going to cut in. You're the only guy sitting up here who's actually done this deed. What do you think?
I've done the deed a lot,
right.
And it turns out, fortunately, there are some people who clearly have PFOs that are related to stroke. And Tony, you know very well, you've probably seen these echoes where there's clot that traverses or saddles across the PFO, and there's no question that some of these folks do in fact have that collaboration or correlation with their PFO when they have a stroke. However, we never see the smoking gun. You just don't see the clot going right to left. And so you're doing it on circumstantial evidence, and this trial, I think, is a major trial which has been years in the making, right? It's taken 5 years to do this. Short version, it doesn't work for this device, and I think you mentioned that.
Yeah.
And this is not the end of the story. This is an unusual device. It is not the most commonly used device. It may be more thrombogenic than other devices. It certainly is not as user-friendly to use as some of the other devices. And I think this story is not finished. We're going to see the results of other trials that are still underway, And I think we just have to wait and see. But for now, I think the data show that anticoagulation is just as good as closure with this device.
So, Chris, you see a 45-year-old woman comes in with a TIA and she's got a PFO and she says, should I have this thing closed? I hear about this. What are you going to tell her?
Well, having trials like this are very helpful, that it's been a series of patients and evidence like that, so that this gives a little bit of pause to say, we shouldn't go rushing in, so, you need this closed, and trying to sort out etiology and look, is there anything pointing to other types of cause of stroke? And certainly anticoagulation is easy enough to accomplish and proven to be as good as what exists here. But then if one could identify a smoking gun or other factors, you could think about it, but it's, I think, leaning away from jumping in with a device.
He sounds like he's in a congressional hearing, doesn't he?
That's a definite maybe.
So, go ahead.
What's really cool is that we got lots of drugs coming along that may be even better.
I wasn't putting you down. I'm just saying. So, Tony, what are you going to do?
I've always felt uncomfortable about putting a foreign body in the heart. God, that's the last place you want some foreign material. And I think now with this evidence, I feel even more comfortable than ever in not doing anything. I do think that in certain circumstances, if you have evidence of venous thrombi that could embolize, if you have a sizable PFO, or as Peter says, if you
valve that's directing it right.
I think under certain circumstances, but in general, in the otherwise healthy person with just the PFO, I'm going to go with the new anticoagulants.
And Peter's going to wait for the ongoing trials. Is that right? You're waiting for things coming up. Okay.
With the new drugs coming up, we may actually just go away from devices completely. I mean,
for PFOs.
We have all this new stuff coming along that really has not been tested, but it will be here shortly.
Okay.
Well, I think I could have stayed in bed today. We've got 3 trials. They're all negative.
Looking at you, you probably should have stayed in bed.
But time out though, Tony. This is a useful negative study.
Very useful. Very. All of them are, I think, very important.
Okay. Well, that's a great point. And on that, we're gonna end, because later today we're gonna be looking at the late-breaking trial Rocket AF, as well as the woman's trial, which sounds very interesting. So we want you to be sure and check back with CardioSource Video News. Thanks for joining us.